patient 1, they're basically the same patients that I saw at 2 weeks interval. And you can read, 39-year-old, fairly syndromic lady, but perfectly working. Giant hemangioma of the left liver, known for 5 years. No symptoms at all, fibrinogen and platelets normal. And I don't know why, but she had a follow-up CT scan. We can discuss about don't know why. And the CT scan and the MRI shows that, in fact, in 5 years, she's gained 1 centimeter per year, and this mass is growing. And still no symptoms at all. Patient 2 is exactly identical. She's 56 years older. Prolactinoma in the past, but 2015 giant hemangioma, normal didymus, fibrinogen and platelets, no symptoms, but the mass is growing and it's big. And it has gained 5 millimeters per year and 3 centimeters in 6 years. Her diademas were increasing, but she has normal platelets and stuff. And I've been raised in the school that you don't operate on these patients. And this is what I told the patient, but if you read, and if the patient goes and read the guidelines, in fact, this is not what's recommended. And it's recommended that if they grow, they should come to us in the MDM and discuss whether resection is needed. And from that, if you go into up-to-date, and the patients can go into up-to-date, they say that if they increase more than 3 millimeters per year, then you should consider resection. And should I really consider resection in these patients who are completely asymptomatic, and one is having slight problem of coagulation, and I wanted to know what you think and what I should tell my patient.
Any questions?
I'm here for the questions, but I'm asking the question.
Okay, I may ask you something. Normally, as you said, we don't really touch these patients. I've seen in my practice huge hemangiomas that we just followed. One woman, 20 years, never had a problem. The only time I saw a rupture was a patient who came in urgently, never saw the patient before, and she ruptured, and it evolved, and there was no sequelae post-op. Usually, I don't even think there'd be a question in not touching this patient unless there was something very symptomatic. As we're taught, they have to crawl into your office in pain before you do any surgery.
Valerio.
Pietro, we have exactly the same kind of patients. We have a couple of them like yours, exactly the same. And we have the same question. I think that patients where now you have to do a right hepatectomy, roughly in both of them, with a growing hemangioma, the problem, if they in young patients, the problem, if they continue to grow, at one moment they become unresectable. And
do they?
If they continue to grow,
who's had a patient who's become unresectable?
Or more,
raise a hand.
Or more complex to be resected. You can do an
I will retire in 4 years.
So. Not this one, but the other one. The other patient with the whole right liver composed of a hemangioma.
This one.
Yes. You showed also another one, the first one.
It's hyalinization. It's necrosis of the infarction. Well, usually, but.
So my concern is in the future for 30-year-old patients with giant hemangiomas of the whole right liver with growing effect. What do they become 10 years later?
Thank you. Daniel.
The treatment shouldn't be more dangerous than the natural history of the disease, in my opinion. I agree with you that when they grow too big, they may be unresectable or more difficult. This is true for central hemangiomas. This one is on the right side, so I suppose you could do a hepatectomy. By the way, if Eduardo Barroso was here, he would tell us that we should do an enucleation. But anyway.
No. And probably he's right.
So, my final comment is I don't think there should be follow-up imaging in hemangiomas, because this is what happens. This is anxiety of the patient. And the anxiety of the patient is parallel to the anxiety of the surgeon. If the surgeon is not anxious, then the patient will be okay. So my take on it is that no symptoms, no surgery. But maybe I'm wrong.
Yeah.
That's what I do.
Yes. Monsieur BISMUTH?
Some years ago, I tried to follow patients with giant hemangioma, more than 20 centimeters, that I follow years and years. And I wrote to them, and one answer, why, it was 30 years ago, and she said, why you ask me the question? For I asked the question, how are you? She said, why? I am perfectly well, 20 years after an angioma of 20 centimeters. But my question is this, why some are increasing and others are not increasing?
I have a partial answer, which is unproven, but I see them increasing in women, and it is known they can be estrogen sensitive.
Can I ask another question? For me, we follow these hemangiomas, but does anyone, what are we afraid of? Rupture and bleeding?
Doesn't help.
Exactly. So why are we even operating on an X-ray?
Actually, it's more solid than the liver.
Yeah.
Yeah. Yes. Yes. This is exactly what I told my patients. Said, contact sports, no problem. And I wouldn't have done the follow-up. They came with me with the follow-up.
A patient like this, she was doing karate at a high level. She said, I'm uncomfortable. What would you say?
Yeah. Now, should we not, as a compagnon, and I would very eagerly take it in charge, write the counter guidelines, because if you see up to date, it is said that they should be monitored and resected. Yeah. And unfortunately, on a paper that goes back to another paper written by Gennaro Nuzzo, and in 2012. Any other opinions for that? Huh?
So you said you stick
We should.
to your rules, to get to your
I told my patients that I would do nothing and stop follow-up, but I would ask you all. The Chinese literature is full of patients operated for hemangiomas, very worrying, or radiofrequency for hemangiomas.
or embolization.
Yeah, yeah, it's full, and I think we should write something about it. And my chief staff is very happy to do it.
In the laparoscopic resection series, you see hemangiomas. Obviously, this is not the type of hemangioma that is done laparoscopically. So that means that they do small hemangiomas.
Yes.
This is wrong, even more wrong.
Yeah. Christian.
Pietro, so you said you want to stop following the patient,
Yes.
but one of them had an increased D-dimer. So would you still monitor that and the platelets?
I would wait. Probably I would wait until she gets symptoms. And if she gets symptoms, one of those I must follow up because she has an IPMN side branch. So she will have to take the hemangioma along for the follow-up or the PMN. And I will have to follow it up. So I will update you on that. Well, thank you very much for supporting. Pierre-Alain, do you have any different opinions?
No, the only, what you need to talk to the patient to make sure he doesn't go to another center, which less experience and with surgery and other things. Because only in Switzerland there's a lot of shopping going on.
Yeah.
Think about Geneva or us. They go, you know.
I will tell the patient.
It's very important, what I say was, embolization never, because they will find someone
Yes.
who is normalized. So you really need, even that sometimes is not enough, but you need to be exactly very convincing, clear patient, yourself sometimes will be this and then follow yourself. So following the patient yourself sometimes prevents this
for that. But I will tell my patient that the topmost liver surgeons in Switzerland have been consensual on that, for you, a Christian.
Indeed, when you see an angioma of 10 or 15 centimeters, it is sure that it increased. It was not born 10 centimeters. That means all angioma increased.
Well, thank you very much for supporting my conviction.